Continuing with the theme, I'd like to take the opportunity to introduce Dr. Sara Hurvitz. Dr. Hurvitz from the University of California, Los Angeles will speak about trastuzumab deruxtecan versus trastuzumab emtansine in patients with HER2-positive metastatic breast cancer, updated survival results of the randomized phase 3 study DESTINY-Breast03.
Good morning. Thank you so much. I'm honored today to be invited by the Planning Committee to present the updated results of DESTINY-Breast03. These are my disclosures. First-line standard of care was established to be trastuzumab taxane with pertuzumab in the Cleopatra trial, and as Dr. Kropp just explained, the Amelia trial established TDM1 as the standard of care after trastuzumab and a taxane for metastatic HER2-positive breast cancer in the second-line setting and beyond. Based upon the strength of the DESTINY-Breast03 efficacy and safety data, which were presented last year, T-DXd is now considered the preferred second-line treatment with TDM1 as an alternative option. At the previously reported DESTINY-Breast03 PFS interim analysis last year, in the T-DXd arm, the risk of disease progression or death was reduced by 72%. The median PFS for T-DXd had not yet been reached and was 6.8 months with TDM1. The DESTINY-Breast03 phase 3 clinical trial enrolled 524 patients with metastatic HER2-positive breast cancer previously treated with trastuzumab and a taxane in the metastatic setting or within 6 months in the early stage setting. Patients were randomized 1-to-1 to T-DXd or TDM1. The primary endpoint was progression-free survival by blinded independent central review, with the key secondary endpoint of overall survival. The pre-specified overall survival interim analysis was planned with 153 events, and at the time of data cutoff, July 25th, 2022, 169 OS events were observed. The p-value for statistical significance was set at 0.013. Patients were, disposition is shown here. The patients treated with T-DXd, 70.8% of them had discontinued therapy. 93% of patients randomized to TDM1 had discontinued therapy. Median study follow-up with T-DXd was 28.4 months, and for TDM1, 26.5 months. Baseline characteristics were well-balanced between the two treatment arms and representative of the demographics of metastatic HER2-positive breast cancer. One notable feature is the high rate of patients from Asia. 57.1% in the T-DXd arm and 60.8% from TDM1 were from Asia. Prior therapies are shown here. For both arms, the median number of prior lines of therapy was 2. About 40% of patients had received 1 prior line of therapy in the metastatic setting. The remainder had received more than 1 prior line of therapy, and 60% or so had received prior pertuzumab. The key secondary endpoint of overall survival at this interim analysis are shown here. As you can see, median overall survival was not reached for either arm. However, the hazard ratio of 0.64 was statistically significantly in favor of T-DXd, with a p-value crossing that pre-specified threshold of 0.013 being at 0.0037. It's notable that patients in the T-DXd arm who came off therapy, 35% of them received TDM1 as standard of care after coming off study. And in the TDM1 arm, 17% of patients who came off received standard of care T-DXd. There was no crossover in this study. Overall survival by subgroups is shown here, and as you can see, TDXD was associated with improved survival regardless of demographic or clinical factors, including hormone receptor status, prior receipt of pertuzumab, baseline visceral disease, prior lines of systemic therapy, or baseline brain metastases. Here are the updated progression-free survival data by blinded independent central review, and as you can see, the median PFS for TDXD has now been reached at 28.8 months. It's notable this is roughly 4 times greater than the median PFS with TDM1 at 6.8 months, with a hazard ratio of 0.33. Nearly all patients treated with TDXD achieved a reduction in their tumor size with an ORR of 78.5% with TDXD versus 35% with TDM1. 21% of patients treated with TDXD had a complete response compared to 9.5% of patients with TDM1. And the duration of response was just over 3 years with TDXD and just under 2 years with TDM1. The PFS2 is shown here. That is from the date of randomization to the second progression event. The median PFS2 was longer with TDXD, 40.5 months versus 25.7 months with TDM1. 182 patients treated with TDXD discontinued therapy. 243 patients treated with TDM1 came off therapy. And in the table below, you see the therapies that were given as standard of care subsequent to coming off study and included monoclonal antibodies, ADCs, tyrosine kinase inhibitors, hormonal therapy, chemotherapy, and other types of therapy. The safety summary is shown here. It's important to note the longer treatment duration and treatment exposure for TDXD-treated patients. The treatment duration with TDXD was 18.2 months versus 6.9 months with TDM1. Grade 3/4 treatment emergent adverse events were fairly similar in the 2 treatment arms, 56% and 51.7%. However, TEAEs associated with drug discontinuation, reduction, or interruption were higher with TDXD. The most common drug-related TEAEs associated with discontinuation with TDXD related to pneumonitis, ILD, and pneumonia, and with TDM1, thrombocytopenia and pneumonitis. The most common TEAEs in at least 20% of patients are shown here. For TDXD, the most common all-grade AEs were nausea and vomiting, 77% and 52%, as well as alopecia, 39.7%, which was higher than seen with TDM1. In terms of grade 3/4 events, TDXD was associated with higher rates of anemia as well as neutropenia, whereas TDM1 had higher rates of grade 3/4 thrombocytopenia. Adjudicated drug-related interstitial lung disease is shown here. You may recall at the first reporting of these data, a total of 10.5% of patients had any grade ILD. At the time of this data cutoff, 15.2% of patients had any grade ILD. However, there were no grade 5 events and no grade 4 events and no additional grade 3 events with the additional follow-up. In conclusion, TDXD demonstrated a clinically meaningful and statistically significant improvement in overall survival versus TDM1, as well as continued PFS benefit. TDXD significantly reduced the risk of death by 36%. The median PFS was nearly around 4 times greater with TDXD than with TDM1. And 78.5% of patients experienced a confirmed objective response. 1 in 5 patients had a complete response with TDXD. The overall survival benefits were observed across subgroups, and with a longer treatment duration, TDXD did continue to demonstrate a manageable safety profile with similar rates of grade 3-4 TEAEs and no grade 4 or 5 drug-related adjudicated ILD pneumonitis events. So these updated results do demonstrate improvement not only in PFS and OS and solidly places TDXD in the second-line setting after trastuzumab and taxane. A plain language summary is available by scanning this QR code as well as additional information. I'd like to thank the patients and their families, the study site, the sponsors, and medical writing support, and I would like to personally acknowledge the scientists, in particular Dr. Dennis Slayman, who did pioneering work in the biology of HER2 and targeting of HER2 over 4 decades ago now. Without this work, we wouldn't be here today. And I'm pleased to also announce that this accompanying manuscript was simultaneously published this morning in The Lancet. Thank you.
Thank you, Dr. Hurwitz. We appreciate your excellent presentation, and we're now open for questions. I will start with some questions that we're getting online. The toxicity is really the concern, the ILD. So the questions online are about what was the monitoring in the trial for ILD? Is there something that you think we all should be doing in the clinic on Monday when we put patients on TDXT or follow up our patients? Is there more aggressive monitoring that could be done to help manage this toxicity?
An excellent question. ILD is certainly the toxicity that raises the most eyebrows because it is life-threatening, as we've seen in Destiny Breast studies. Not in this study. This study and others now incorporate Q6-week monitoring with CT scans, so the lungs are being monitored very carefully. And if a patient develops infiltrates or ground glass opacities in the lungs, even if they are completely asymptomatic with a normal O2 sat, treatment must be held. It should not be resumed unless it has resolved, and we even think about using steroids with that grade 1 ILD. Any patient with symptomatic ILD should have therapy permanently discontinued. We do not have data to support resumption of therapy in patients who have had symptomatic ILD. And in clinical practice, although many of us will pull back on the frequency of monitoring scans in the metastatic setting for patients who do really well, I would encourage you to stick with the protocol-specified monitoring of the lungs, especially the way that it was done on the study. I think only by monitoring closely are we going to get results like we saw here.
Thank you. Question 5.
Vogel, New York. Sarah, wonderful presentation. Vogel, New York. Sorry, the mic wasn't on. So you've shown clearly that all antibody drug conjugates are not created equal. One is a lot better than the other. What's the path forward? Is the mechanism of resistance the target antigen being hidden? Is the mechanism of resistance the target of the payload being hidden or bypassed? Maybe you should give this drug for 1.5 years and change to a different target.
Excellent question, Dr. Vogel, and I think this is the area that is very rich with research now, both from tissue specimens from the metastatic trials, and in the next presentation, my colleague Dr. Bardia will be presenting neoadjuvant data. I think these neoadjuvant studies that allow us to sample tumor tissue pre and post therapy will help inform what is going on biologically in situ in the tumor tissue. So I really do want to stress the importance of these types of biomarker studies in helping us interrogate these important questions.
Okay, one more question. Microphone 3, please.
Kathy Miller, Indiana. Thank you, Sarah. Certainly great day and great data for patients who are treated in areas where this drug is commercially available. The low rate of crossover suggests that might not have been the case for the majority of patients in this trial. Do you know how many patients were treated in regions where that was an option for them post-progression?
It's an excellent point. Thank you for recognizing that. It is a lower rate of crossover from TDM1 to TDXD, only 17%, which is half of the rate of crossover from TDXD to TDM1. And yes, it most likely is due to the higher population from Asia countries where this drug is not available as standard of care in all those regions. We have not looked specifically, and I don't have that data for you today, based on rates of crossover by region, but that is a very important factor that we will pay attention to as we continue to follow these data.
Okay, we need to move on for time reasons. Thank you, Dr. Hurvitz.